please.
Thank you for joining us today. Before we officially begin, I would like to start with a few housekeeping items, some information about the webinar. First, the webinar will be conducted in English. There will be no interpretation to other languages. Please use the chat function at the bottom of your screen if you need support with technical problems, connection, sound, or if you wish to send welcome message to us or say where you are from, please use the chat function for this. Participants are invited to ask questions to the presenters and panelists using the separate Q&A function, also on the bottom of your screen. So the Q&A function is for asking questions to the presenters and panelists. We may not have time to answer all questions live. This is why presenters and panelists might also respond in the Q&A. And please note, finally, that this webinar will be recorded. Now we can start the recording, Jazzy, and we start with the official program.
Okay, Tibor.
So now I would like to formally welcome you all to the launch of the publication of the WHO FCTC Secretariat, which is called Implementation Practices in Smokeless Tobacco Control. My name is Dr. Tibor Szilágyi, and I'm the coordinator for reporting and knowledge management in the Convention Secretariat. Smokeless tobacco kills over 350,000 people a year. Among the nearly 350 million smokeless tobacco users worldwide. We are talking, therefore, about an important publication here, as this report represents a milestone in promoting to apply the requirements of the WHO FCTC to smokeless tobacco use. Before we move on, I would like to acknowledge those who have made the publication of this report possible. The development of this publication was commissioned by the Convention Secretariat of the WHO Framework Convention on Tobacco Control and the Protocol, and a number of colleagues contributed to it. Their drafting, reviews, inputs are warmly acknowledged. We are also grateful to Norway, whose financial support made this report possible. Let me give you a quick overview of today's webinar program. We shall start with a welcome address from Dr. Adriana Blanco Marquizo, head of the Convention Secretariat. Then we will have a session setting the scene for our discussion, and in that section of the program, we will have presentations from Dr. Shalini Singh, Director of the WHO FCTC Knowledge Hub on Smokeless Tobacco, and Director of ICMR, National Institute of Cancer Prevention and Research in Noida, India. And the other presentation will be made jointly by Dr. Dhirendra Sinha, who's the Director of School of Preventive Oncology in Patna, India, formerly Regional Technical Advisor, TFI-CRO, and Dr. Amit Yadav, Senior Technical Advisor of the Union Southeast Asia Office in New Delhi, India. We will then move on to our panel discussion that will be moderated by Mr. Kelvin Ko, my colleague in the Secretariat of the WHO FCTC and the Protocol. And we will have distinguished panelists to discuss policy issues related to smokeless tobacco control. Then we will have a question and answer session to respond to some questions from the audience. As I said, the audience is kindly required to pose any questions in the Q&A functionality in the bottom of your screen. So please pose your questions there. And I would also kindly ask the presenters and panelists that during the webinar, if they see that there are questions that are addressed to them, try to also respond in the Q&A functionality, as we might not have enough time to respond to all questions live. And then Dr. Shalini Singh will join us again and deliver some closing remarks with myself, and I will be your moderator for today. And now, without further ado, I would like to invite Dr. Adriana Blanco Marquizo to make some welcome remarks. Dr. Blanco Marquizo, you have the floor.
Thank you, Tibor. Good morning from Geneva, and on behalf of the Secretariat of the WHO Framework Convention on Tobacco Control, or WHO FCTC, as we usually call it, and welcome to this webinar. As co-sponsor of this meeting, I'm delighted to be presenting this important report on implementation practices in smokeless tobacco control. I want to acknowledge the work of Dr. Dihendra Singh, who led the preparation of this document, and all those colleagues who have contributed during its finalization. I also offer my thanks to the government of Norway, which provided funding. I said the report is important, and I mean it. Smokeless tobacco, just like smoked tobacco, kills and produces a range of serious health conditions. But there is the common belief that products such as chewing tobacco, for example, are somehow safer than smoked tobacco. And that is not true. At least 550,000 people a year die by using smokeless tobacco products. Smoked tobacco, in particular cigarettes, are the biggest problem in many regions. But in South Asia, smokeless tobacco is much more popular and represents an enormous health problem. That reality has moved the tobacco control community to look for imaginative and effective responses. Examples of these practices are included in the report. We hope that this will provide inspiration for those WHO FCTC parties that have not yet tackled the smokeless tobacco issues head-on. And sadly, that still applies for many parties. The convention is clear. Its definition of tobacco product includes products for smoking, sucking, chewing, or snuffing. Therefore, all the provision of the convention, perhaps with the exception of those related to tobacco smoke, should be applied to smokeless tobacco products. The Convention Secretariat is determined to cooperate with parties to confront this issue, and we are working hard to provide evidence-based guidance. Right now, we are collaborating with the WHO FCTC Knowledge Hub on smokeless tobacco and the Campaign for Tobacco-Free Kids on a manual to help parties strengthen their laws to provide a firm backbone for effective smokeless tobacco control. We are also collaborating with WHO to ensure that this Global Oral Health Action Plan highlights the impact of tobacco products and specifically smokeless tobacco on oral health. The prevalence of tobacco smoking has declined in those countries that have comprehensively applied the convention. We have learned lessons from this work, which we can now apply to smokeless tobacco too. For example, some of the work in India has been fabulous. I'm thinking especially of the campaign to ban gutka, which has been intelligent and relentless. Gutka, a chewing tobacco made with betel and other ingredients, is a leading cause of oral cancer. Whereby government, non-governmental organizations, and medical staff concentrated on multiple avenues of attack against this product, which is not only unhealthy in itself, but also unhygienic because users has to spit out the saliva. The message is that carefully thought out campaigns which bring together government, professional, and activists can bring big victories. Thank you once again, and I hope that you will benefit from the good practice examples contained in today's report. Thank you very much.
Thank you, Dr. Adriana Blanco Marquizo, Head of the Convention Secretariat, for your encouraging words and also for summarizing the efforts of the Convention Secretariat to promote implementation policies on smokeless tobacco, together with our other partners, including WHO colleagues and the WHO FCTC Knowledge Hub for Smokeless Tobacco. Thank you again for that. We will now proceed to a session on setting the scene for our discussions. In it, there will be two presentations. First, I would like to invite Dr. Shalini Singh to give her presentation. Dr. Singh is the director of the WHO FCTC Knowledge Hub on Smokeless Tobacco and director of ICMR, National Institute of Cancer Prevention and Research in Noida, India. Dr. Singh will speak about the challenges and the importance of addressing smokeless tobacco. Dr. Singh, you have the floor.
Thank you, Tibor, and greetings from the WHO FCTC Knowledge Hub on Smokeless Tobacco at the National Institute of Cancer Prevention and Research, Noida, India. I'm very pleased to be a part of this event, which will to launch the publication on implementation practices in smokeless tobacco control. As Dr. Adriana has emphasized enough, that smokeless tobacco has been considered to be less harmful and a safer alternative to smoking. So we, in the Southeast Asia region, have the largest burden of smokeless tobacco. So going along, I'll show you some examples of how dangerous this product is and what harm it is doing to the health of the people in this region. So as you can see the screen, it shows the prevalence of smokeless tobacco use in the countries across the world. The highest burden is in the regions where the color is showing red or yellow. And as you can see, the India and Bangladesh and the Southeast Asia region stand out. The map, which is on the top, is representing the females, and the lower one is representing the males. Coming to the tobacco epidemic in the country, nearly 28.6% of people are tobacco users, and amongst them, the smokeless tobacco users are 21.4, whereas the smokers are just 10.7. So we definitely have a higher burden. But most important is that less proportion of smokeless tobacco users are planning or thinking of quitting its use. And also that the healthcare providers advise the smokers more often than the smokeless tobacco users to quit its use. So which is an important for clinical practice. The hospital-based cancer registry also indicates that 33% of all cancer cases were associated with tobacco use and are therefore largely preventable. So much can be done to prevent these specific sites of cancers which happen due to tobacco use. The smokeless tobacco products, apart from containing nicotine, which is addictive, have several kinds of carcinogens, namely, most importantly, tobacco-specific nitrosamines, which come from the tobacco alkaloids during curing, fermentation, and aging, then N-nitrosamine acids, the volatile N-nitrosamines, the polycyclic aromatic hydrocarbons, the aldehydes, and heavy metals like cadmium, uranium, and polonium. But the most important thing to note here is that the commercial smokeless tobacco products available in India have a higher concentration of these carcinogens, as has been seen in this study, as compared to the European products. This study is comparison between the Indian product and the Swedish product. So definitely it has an impact on the health of our people. Apart from cancer and of different organs, cardiovascular diseases are responsible for nearly half of the death of its tobacco users. And the death is much higher in the younger tobacco users. So you can see in the pie chart that cardiovascular diseases, they constitute nearly 48% of deaths among its users, whereas cancers constitute only 10%, and the other causes are also shown. And the age-specific distribution of deaths is also shown in this figure, which shows that the people who are younger in age, 30 to 50, 60 years, are affected more by cardiovascular diseases. This is because they have seen in the study that the plasma nicotine levels after administration of smokeless tobacco are sustained for prolonged periods, and the overall amount of nicotine absorbed is twice as high as that of a single cigarette, because the product remains in contact with oral mucosa for prolonged periods, and it bypasses the liver and reaches the circulatory system straight away. The metabolites of tobacco like cotinine and NNAL have also been shown to be significantly higher in the blood and urine of SLT users than in those of the smokers. Now, coming to the challenges of smokeless tobacco control, it's widely available, it is socially acceptable, it's culturally rooted, and it's very lucrative. We get cheap labor in the form of children and women who are making the products in their cottage industry or in their own homes. There are certain beneficial effects which people perceive as myths that they continue to use these products. Smokeless tobacco products use starts at an early age, much earlier than smoking, and there are several gender issues also attached with its use. Then these products are mixed with areca nut and pan, and they are culturally acceptable, also used in religious events. Apart from this, spitting even is also culturally accepted and people don't seem to mind it. Of course, the major problem is that we have surrogate advertisement of these products. All kinds of laws are there, but implementation of these laws is a big challenge, especially when celebrities are endorsing these products. Also, that there are different kinds of products, various preparations of these smokeless tobacco products, and we do not have a standard packing. Therefore, the display of pictorial health warnings is also not easy. Then they're using plastic packaging for these substances. And we have also found in various other basic science studies that there are fungal and bacterial products, as well as these colonies inside the smokeless tobacco products. These publications are in process. Then the licensed manufacturers are not possible because they're home-based productions and cottage industry. Then there's no tracking and tracing mechanism. While the use of tobacco products cannot be mixed with food items, we still have the use of additives, scents, sweeteners to increase the appeal of these products. And also the trademarks of non-tobacco products are being used by the tobacco industry. While the WHO report has pointed out to the environmental hazards of cigarettes, the menace of smokeless tobacco has not been popularized much. And there are tons of plastic pouches in which these products are sold, which litter the environment every year. Another big problem is that it is more popular amongst women than smoking, and nearly 12.5% women consume these products, including 7.4% of pregnant and 5% of lactating women. And they use it, sometimes they initiate during pregnancy for gum pain, constipation, morning sickness, and all these kinds of things. There is more social stigma attached to the use of tobacco, so the women do not reach out for counseling or other health problems. Then children, of course, are employed as labor. Apart from that, spitting is a big problem, as also been pointed out by Dr. Adriana, and the Smokeless Tobacco Hub was instrumental in instituting these ban notifications in various states during COVID-19. Finally, we need definite interventions for smokeless tobacco cessation, either pharmaceutical or behavioral or combined. And also the interventions should be applicable to both the use of both smokeless tobacco as well as areca nut products. Finally, we cannot overemphasize that Southeast Asia has the highest prevalence of tobacco use in the form of smokeless tobacco, and WHO FCTC guidelines should be paid attention to and help in the countries in overcoming this menace. Thank you very much.
Thank you, Dr. Singh, for that very informative presentation, starting from the contents in carcinogens, especially of SRT products, and the health impact of using smokeless tobacco products, and the listing of the many challenges that that we are facing when trying to control smokeless tobacco products. So your presentation already implies that there's no room for complacency in progressing towards stronger policies to control smokeless tobacco use. So thank you very much. This was very important in setting the scene for our talks today. And I'm sure that we'll be able to provide more details on some of these aspects during the other presentations and also in the panel discussion. We shall now proceed to the next presentation that will be made jointly by Dr. Dhirendra Sinha and Dr. Amit Yadav. As I introduced Dr. Sinha already, he is the director of the School of Public Health in Patna, India. And he was formerly with the WHO Regional Office for Southeast Asia, where he worked in tobacco control. And this is the time when we first met with Dr. Sinha, when we started working together on surveillance issues and tobacco control in general in the Southeast Asian region. And that was for many years. Dr. Amit Yadav is a senior technical advisor at the International Union Against Tuberculosis and Lung Disease, simply named the Union, in the Southeast Asia office of the Union in New Delhi, India. The Union is an NGO that holds the status of observer to the Conference of the Parties to the WHO FCTC. Dr. Sinha and Dr. Yadav will speak about the current status in smokeless tobacco use and policy options for regulation. Dr. Sinha, Dr. Yadav, you have the floor.
Thank you very much. So we have heard so many technical information from the earlier orators that my duty has been shortened. So they have said everything. But we will focus on that. I will be focusing on that how this, next please, next slide please. How this document implementation of practices in the smokeless tobacco control. There are so many pieces of such kind of work worldwide, but they have seen in bit and pieces. But this is the first effort of the FCTC Secretariat to capture in a small text that what is happening in the world. I'm very happy that I had initiated this this manuscript, but I see that this has been finally signed off by the WHO colleagues also. Next, please. This document has mainly focused on Article 9 to 14 and Article 20. Because there were some limitations of size also, and that's why I have chosen the articles where there is something to show. And those articles from 9 to 14 and Article 20 has some good practices that you can visualize, and it can be used as advocacy documents. And I have not used certain articles because we don't have information for all articles equally to showcase. This time my presentation is limited to Article 20 of the WHO Framework Convention on Tobacco Control, which includes surveillance, research, and exchange of information. Next, please. Next, please. The surveillance includes the market surveillance of the tobacco SLT products. While I started this work in WHO, I went to Myanmar and I met my colleagues over there, government colleagues and NGO colleagues, and they said that there is no market of SLT product. Dr. Nyonyo, some of you must be remembering her, that she was the country focal point in Myanmar. But when we went throughout the market, there were several kinds of products filled in so many nooks and corners, and there were big markets also. So, and the WHO FCTC Secretariat and WHO has done wonderful work in the previous publications that, and I have also added my work. So we can say that it is available in at least 166 countries in the world. Of course, this is not marketed in many countries as product by the manufacturers, but used in the communities of tribes, etc. And most importantly, in the near future, we have gathered information on smokeless tobacco use surveillance. And I am happy to indicate that there is at least one study either on adult or on youth in 140 countries for one time. But there is, when you use tobacco use surveillance, meaning thereby you should have a periodic data at the and you should use the standard questions and the standard methodology to know that. So when we come to this, there is hardly countries to name it. Then SLT product wise, many countries now in Southeast Asia, they have done the surveys which informs that what is the prevalence of different products in those countries. And I can see that India, Bangladesh, Myanmar, and Sri Lanka are those countries, and Bangladesh are those countries. In Thailand also, that has obtained the product-wise prevalence of smokeless tobacco use in adults as well as in youth. So this is very much limited. Then age-wise, so I saw one definition that has been used by Empower. So if you have adult tobacco surveillance and youth tobacco surveillance together, then we say that there is complete information. So many countries, India was also not within that. But now India has completed the GYTS. So this is as one of the best countries in surveillance. Then we have little information on consequences of use by quantity, frequency, time, and reversal. This information comes mostly from the longitudinal studies of long time. Of course, there has been lots of studies in India and other countries, but the information is very much limited. Then coming to surveillance of the other SLT use indicators as per the knowledge and the risk perception. Of course, the newer studies are there at the regional level or at the country level in some of the countries, meaning there were 4 or 5, 6 countries. if we count a good surveillance system and what the government has done. So I can say that India is one of the best countries where the government has taken the responsibility of doing 2 rounds of global adult tobacco survey and the present 4th round of global youth tobacco survey. And many countries are moving towards that or adopting some of the TQS questions in their national surveillance system. Next, please. So from the this surveillance, we at least know that nearly 10%, around 8.4% of the global adults, they are using smokeless tobacco in one or another form. And as the previous speaker has pointed out, that the prevalence in the Southeast Asia region is high, that is around 25% of the adults, 25% or above, the adults are using SLT products in one or another form. This is at least for the now the comparable SLT tax incidence rate. Then we have limited number of countries. This was a publication that I, Amit, and economists have done. So there we found that only 35 parties have the comparable tax incidence rates. Coming to the health harms, Dr. Salini has rightly pointed out that it not only causes oral cancer, esophageal cancer, or the pancreatic cancer, but it also causes several kinds of diseases in the heart. And nowadays, it is noticed that the smokeless tobacco users are getting more heart attacks as compared to the non-users. But it has not come in a big way in the literature. So this is limited. The limited studies are there on mortality risks of major diseases. And then reversal of the disease. You must be knowing that if you give up the smoking, in how much time, what is the change in the body, in how many days, what are the changes in the body, in how many years, how you are protected from the different diseases like cancer or the other diseases. But that information that when you give up the smokeless tobacco, this is not very clear. This area is very gray. We have published just a paper that there is improvement in development of oral, pharyngeal, and esophageal cancer. 25% chance will be, there will be 25% less chance to have these cancers. But it needs to be worked out, and I think we need to report this area. And then the data dissemination. In the recent years, there has been a lot of data in each and every country, but they are not being kept in the public domain. Meaning thereby it has the government has incurred money over there. This is government money, but some institutions, they have hesitation to put these data in public so that the secondary analysis and so many other researchers can go through this. Then publication should be encouraged. Why I am telling this, that 90% of the smokeless tobacco use are in the countries which are poor, and they do not have capacity to capture those data, or they do not have capacity to write good publications and publish it. So there we need to work out with the countries, with the poor countries, to increase the publications. Then there are case reports and follow-up. This manuscript is one of the example. So some of the best examples of the publication we can see that it has come from the IARC monographs number 85, 89, and 100E. Then IARC handbook on prevention of oral cancer, that is especially related to the smokeless tobacco. The recent volume is coming. We were involved in that, so that is also a good publication. And one of the important finding is that the smokeless tobacco cessation work on adults, not on youths. So this is a very important finding from the cessation meta-analysis. Then FCTC progress reports, some recent reports from last 10 years, they are reporting the findings on smokeless tobacco, different variables, and they have come up with the short reports like the present one. Then WHO Empower reports also nowadays report the prevalence and the other factors related to the SLT. Then there has been global publication from the help of the NCI and the CDC, SLT and public health, a global perspective. And very recently, 5 years back, the India government has also initiated and the monograph has been published. And the our Global SLT Hub, they have also published a monograph on implementation of the policies that is in the global perspective. But it has become now old. We need to just redo exercise and update this. Then we have done several special issues of the journals on SLT. So nowadays we have got the literature. Then exchange of information of the production, of the trade practices, and the black marketing. This is the area which has not been worked by the scientific community or by our organizations involved in the tobacco control issues. Always we have to go to Eurometer. So I can just conclude in saying that the continued advocacy on implementation of the Article 20 with lots of advocacy materials should be continued. Thank you very much.
Thank you, Dr. Sinha. I will take it from here. I think Dr. Sinha has set the context, and what I am going to do is look at from the FCTC lens and the policy aspects which we can use for regulating SLT. Again, it comes from the framework convention. So the first one in terms of prevalence, as already Dr. Salni and Dr. Sinha has already said, that the highest number of use is in our region in Sierra, and this is the problem. And if we look at globally, about 23 parties, the study that Dr. Sinha was talking, we did, more than 1 million people use SLT, adults have been using, and this is the 95% of global SLT users live in these 23 countries. And highest is in the region which you can see on the graph. So in terms of FCTC policies, so first one is taxation, and we see that this has not been used as a active policy or effective policy to reduce SLT use. And I think Dr. Sinha also presented that the comparative price for cigarettes is like for the SLT prices are very low. And I think it's generally have been lower. And studies have shown that if you increase SLT prices, then its consumption drops significantly, because we are talking about poor people who are price sensitive. Then 9 and 10, I think this is also one area where COP has been discussing, and this our knowledge hub was established also to look at how to best regulate this product, and that is where what kind of toxicants are found or in terms of how nicotine content or tobacco specific nitrosamines. So these need to be studied, and a standard protocol was supposed to be developed. And I think this is one area where in terms of product regulation, we are still working. I think a lot of research has come out from the Knowledge Hub and NICPR on these issues. India has established national tobacco testing labs as well, and I think this is in progress in the region. And we hope that there is more available technical approaches to reduce toxicants in SLT, and this work continues on this line. In terms of pictorial health warning, again, smokeless tobacco, pictorial warning on smokeless tobacco has been inconsistent, and when we compare it with cigarettes. So I think parties should consider putting or doing no distinction between SLT and cigarette products or smoking products. We see that only limited number of parties have 50% or more size of pack warnings on SLT products, while it is more in the parties for cigarettes. So this is another important and effective measure that we need to work, we need to implement on SLT products as well, without any discrimination with the smoking form of product. In terms of awareness also, we see Article 12, we see that India has done a lot of these mass media campaigns. India also have the film rule. Under the film rules also, there has been these testimonies which were displayed in the cinemas, these documentaries. I think lately even Myanmar also came up with a testimony, Nepal and Bangladesh as well. So these are some of the mass awareness campaigns that has happened in the region. I think these can be replicated in other countries which have a high SLT burden. In terms of advertising, again, we see that very limited number of parties had comprehensive bans on tabs when it comes to SLT products, and even the sponsorships. And I think even point of sale advertisement ban has been not to the full. So I think implementing these FCTC provisions to its highest level is, I think, one of the immediate and important policy suggestion or policy recommendation that can be forwarded. In 14, as again Dr. Sinha was talking about it, there's very limited number of SLT users are being advised by the health providers to reduce SLT use. Whereas even we are struggling that NRT is not part of essential medicine list for majority of the parties. So that is another important area in terms of advancing SLT cessation, which needs to be discussed and implemented by the parties. Training and e-learning, I think that is one of the recommendations that had come during international discussions, and also in India when we did national consultation. I think this is important for advancing tobacco cessation to the people where it matters. Article 15, now we have a dedicated protocol on this illicit trade in smokeless tobacco products. So we have the eliminating illicit trade in tobacco products protocol. Several countries have issued licensing or required licensing requirement for SLT products as well, and regulate the production, distribution, and sale across different categories of industry. While the protocol talks about key areas which I think should be again implemented irrespective of the kind of product, whether smoking or a smokeless product, which would include licensing, tracking and tracing, record keeping, and regulating free zones in international transit and duty-free sales. And this should be implemented for smokeless tobacco. While the protocol gives more time for non-smoking or non-cigarette products, but I think walking together would be easier than doing one after another. So I think that needs also to be highlighted. Protecting minors. This is as per the global reports under Empower and other documentation. It says these 4 areas: placing warning at point of sale, prohibition of display, and ban on product in the form of sweet toys and candies, and prohibition on vending machine. These are 4 criteria under Article 16, which needs to be implemented to make sure that minors do not get access to tobacco, including smokeless tobacco. So only 13% parties met these 4 requirements, while several other would meet one or other criteria, but not all the criteria. So this direct access at point of sale and loose sale of tobacco actually is identified as a major concern, and we need to work towards meeting this gap. Several states in India have also notified ban on loose sale, and there's a state of Himachal has required passed a legislation also to ban loose sale. This is one area where even the pictorial health warnings are compromised, because if you are selling it loose, people do not see the warnings on the pack. So that's another problem. Certain countries have also taken beyond FCTC measures as well, like ban on SLT products completely, which is also important. There are some countries which have full or partial ban as well. Some of the countries have banned manufacture, where some countries have banned import of SLT products. So these are also taken as important tobacco SLT control measures, and especially countries which have minimum burden of SLT use, for them to prevent it in the early stages, it is better to go this way. One of another aspect of SLT ban has been prohibition on spitting in public places, because SLT use normally induce a lot of spitting. So this was done in earlier for reducing communicable or preventing communicable diseases, or maintaining public cleanliness, hygiene, reducing SLT use. And also recently we saw that during COVID-19, to prevent COVID-19 transmission, even ICMR and Ministry of Health, they issued guidelines in India to ban smokeless tobacco use, sale, and spitting in public. Now, this was done in other countries also. There's fine on spitting in public places in several of these countries. Nepal, Bhutan, Myanmar, Papua New Guinea. So there are examples where ban on spitting in public places is being done. In India, several municipal corporations and state governments have taken up this. And during COVID period, more than 300 districts in the country across 25 state and union territories had also completely banned spitting and sale of tobacco products, especially during the lockdown period, so that it is not available and to mitigate COVID transmission. So overall, the key message, the best way forward is to implement and fully implement all the FCTC provisions with respect to smokeless tobacco products as well. However, SLT, because it is coupled with areca nut, which is not regulated under FCTC, and so prevents a complex policy and regulatory challenge, which we are also facing in India. In India, tobacco control laws have applied equally to SLT products, and I think this should be the best practice across the globe, where should not make any discrimination on smoking or non-smoking products. Several parties have gone beyond FCTC, as we have seen. Government of India have also taken steps under other laws, Food Safety, Juvenile Justice, and Consumer Protection Act. Food safety regulation has been important, as even Tibor was saying, and Dr. Blanco was also talking about that. And juvenile justice in India, if anyone gives tobacco to a minor below the age of 18 years, the penalty is up to 10 years imprisonment and up to 1 lakh Indian rupees fine, 100,000 Indian rupees fine, which can be imposed. So, and even the Consumer Protection Act now limits surrogate advertising, which is a challenge that we are looking at. Several parties to the FCTC have implemented complete or partial ban. That is another important area that others can also follow. So that's all from my side. Happy to take any questions on these slides. Thank you.
Thank you very much, Dr. Sinha, Dr. Yadav, for this comprehensive presentation. We heard about challenges related to data collection for smokeless tobacco use or surveillance of SLT products from Dr. Sinha. These are very important points which we need to strengthen in our implementation of the FCTC. And Dr. Yadav, this was a great summary of and examples of some policies. Some of them are referred to in this publication. So you almost made my presentation obsolete, but I can certainly cut it short. But very good that you also demonstrated that examples are available on areas that are not covered in the present report. So that means already that the publication of this report is just the beginning, because we need to continue documenting and disseminating information about best practices. So thank you very much for summarizing that. And the next step would be for me to let's say summarize the content of this report. And I put together a few slides which I would like to share with you now. But I will certainly shorten my presentation, because you have heard of many examples already on the implementation of various FCTC articles or how to apply these articles to smokeless tobacco use. So we are today to launch this presentation, this publication on implementation practices on smokeless tobacco control, which we prepared, and which document was prepared based on some previous requests and mandates given to us by the Conference of the Parties. And I would like to specifically refer to the decision of COP6 in 2014, which was focused on smokeless tobacco products and invited parties to develop product-specific policies in various articles to the convention. Furthermore, it was in the same decision that called to establish a knowledge hub focusing on smokeless tobacco to document best practices and implementation challenges related to smokeless tobacco products. And as you have seen from the previous presentation, and this is what I would like to highlight as well, that this publication, which we are launching today, and the entire operation by the way of the Smokeless Tobacco Knowledge Hub is carried out against this backdrop, against this mandate given to us by the Conference of the Parties. And here you see the contents of this document, which we are launching today. And as Dr. Sinha said, it covers some articles to the convention, but not all. It covers Articles 9 to 14 and Article 20 of the Convention. So this is why, as I said, I think the work should continue. Documenting and disseminating implementation practices should be a continuous work as parties strengthen their implementation of the Convention, also with respect to smokeless tobacco use. Future work will need to investigate implementation policies, implementation practices for other WHO FCTC articles, such as taxation of SRT products, access to and sales by minors, and others. The discussants participating in the panel discussion that is part of this webinar will have the opportunity to highlight additional developments that have occurred after the finalization of this report. And I would like to also highlight that later today, another forum will also focus on smokeless tobacco policies. Organized by the Johns Hopkins University, a talk by Professor Kamran Siddiqui of the University of York will focus on policies related to smokeless tobacco use in low and middle-income countries. In that talk, Professor Siddiqui will argue that in recent years, evidence has emerged that most tobacco control policies that work to control smoking would also work to curb smokeless tobacco if implemented with the same rigor. This is a very important message, and this is why I would like to invite you all to visit the website of the Institute for Global Tobacco Control and register for that talk later today. And I will skip these examples because they just list what are included in the report, and some of them have already been referred in the talk by Dr. Yadav. But I would like to focus, and that was also touched upon by Dr. Yadav, that we have also two examples in the report that worth highlighting, because one of the examples, that from Sri Lanka, addresses SRT control comprehensively. They introduced an SRT ban, plus communication efforts, plus illicit trade control for the same. I would like to also highlight is we have Article 2 of the Convention, and more precisely Article 2.1, that calls upon parties, or based on which the parties have the opportunity to go beyond the requirements of the FCTC. And some of these examples of going beyond are included in the report and were included in the presentation of Dr. Yadak. And as it has already been said by other speakers, in spite of good examples, challenges remain. There are challenges related to putting policies that look very nicely on paper, putting them on practice and actually enforcing them, because only doing that we will be able to strengthen our control of smokeless tobacco use and making these policies efficient, which will have later on a health impact, a beneficial health impact. For parties without SRT-specific policies, as Dr. Blanco Marquizo has already referred to, existing tobacco control laws and regulations should be updated to include SRT. And for doing that, political will and multisectoral action will be essential. We need to monitor SRT producers, the cottage industry, and the tobacco industry. This is necessary to understand how they expand their business and how they interfere with policymaking. And we read about a case study in the Q&A functionality that is still in the court in India. Please read that story, which refers to an article in Tobacco Control. This is very instructive on how much efforts the tobacco industry puts in delaying, derailing, in making the policies inefficient, which we need to prevent. And finally, I'm sure that Dr. Singh will be highlighting that again and again, that support and information to address SRTs can be obtained from the WHO FCTC knowledge upon smokeless tobacco and upon request by the parties to the convention and the countries. The Knowledge Hub could provide them with assistance. So this is now the opportunity that I would like to use to ask my colleagues to put up in the chat or even the question and answers functionality the link to this report, which is already there. Thank you very much. So you all have the link to the report, which we are launching today, which is now available on the website of the Convention Secretariat. Please take it, use it, read it, and implement policies that are in line with those, complement those, or go beyond those. So this is where I would like to stop my presentation, not taking more time, and provide some more time to the panel discussion, because I'm sure that the panel discussion which will have distinguished panelists will provide us with the opportunity to hear about additional examples, additional efforts, additional policies related to smokeless tobacco control. So we shall now proceed to the panel discussion. I will hand over the moderation of that session to my colleague in the Convention Secretariat, Mr. Kelvin Ko. Kelvin is Program Manager for the WHO FCTC in the Convention Secretariat. Kelvin, you have the floor.
Thank you, Tibor, and thank you again to all the previous speakers for really setting the scene for us with that very rich background and foundational presentations. So without further ado, we'll just jump straight into the next part of the webinar, which is to hear from, we have 5 distinguished panelists. It'll be a bit of a hybrid because we have a couple of short presentations, but then we'll also have some live interventions coming in. So without further delay, I'm going to invite Dr. Jagdish Kaur. She's the Regional Advisor for Tobacco Free Initiative at the WHO Regional Office for Southeast Asia, based in New Delhi. Dr. Jagdish, would you like to share your presentation? Yes. So Jagdish, you will tell us about the support that the regional office is able to provide to countries. What have you been doing in terms of controlling SLT, and what are some of the priorities and strategies that you're implementing? So Dr. Jagdish, over to you, please.
Thank you so much. Thanks. So going right into the presentation without wasting further time, I'll be, can you see my presentation?
Yes, it's not on slide mode though.
Just a minute.
Yeah.
I'll do that.
We see it as
Is it now? Is it in the slideshow?
No,
mode?
it's still in
Why it's not, but
oh yeah, now it is. All right.
okay, thanks. Okay. So basically, I'll be going by Empower, how we are doing that, because through Empower, we are basically regularly measuring, the 6 demand reduction strategy, how they are going. As very rightly pointed out by Adriana and my speakers who spoke before me, that FCTC, it applies to all tobacco products. So smokeless tobacco is included, but then we need to be taking care of many other things which are not happening. So if we look at Empower, M of Empower, then monitoring of smokeless tobacco use and its various determinants is prioritized in the member states which have high prevalence of smokeless tobacco use. So we encourage them to have questions on smokeless tobacco as well as Erica nut use. Like somebody had posted in the chat that this Erica nut part of it is being neglected. Yes, it is, but we are now collecting data on regular basis, both for adults as well as for youth, to see that, how these products are being used, and also the relevant policies which apply to these products. In fact, we encourage parties to include TQS for both these products, smokeless tobacco and Erica nut, to be integrated with national health surveys and multiple risk factor surveys, like we have steps for NCDs. And we are now generating quality data, which is there for policymakers to see for policy development, reforms, and policy synergy. We are also providing cessation services aimed at smokeless tobacco products, and also for both adults and youth we are targeting. We recently launched WHO Quit Tobacco app to help people quit tobacco in all forms. And this app is available both for Android as well as iOS versions. So please, whoever is listening to this webinar, tell everybody to use this app. This is very comprehensive. It takes into account cessation of smokeless tobacco. We are also supporting nicotine replacement therapy trainings in different countries, and that continued through the lockdown period during the COVID-19 pandemic. And we supported India and Timor-Leste with donated NRT products from CIPLA, which they have been using through their various outreach programs, which included setting up of first tobacco cessation clinic in Timor-Leste. So these were quite focused programs. And in India, this was led by Indian Dental Association and smokeless tobacco, of course, because, it's consumption of oral chewing tobacco was a major part of it. And countries, this was pointed out earlier also, that we had media campaigns in high tobacco use, smokeless tobacco use prevalence countries, focusing on smokeless tobacco. India and Myanmar was mentioned. Also, as part of WNTD World No Tobacco Day 2021 Commit to Quit, we ran intensive social media campaigns which included smokeless tobacco. If we look at these media campaigns, so this was basically to warn people regarding the harmful effects of smokeless tobacco, which are not known as they are known for the cigarettes. And now we have evidence, and so based on that evidence, the campaign material was prepared. We are also performing well in implementing large graphic health warnings on packages of tobacco products, which includes smokeless tobacco. So high prevalence countries, they are having these warnings, graphic health warnings on all the tobacco products. And countries have laws in place to counter taps, and that also includes smokeless tobacco products. We are continuously sensitizing member states to increase tax on tobacco. Amit mentioned that, it is not kind of like we tax cigarettes, So of course, if we take example of India itself, BDs are taxed very low, as well as smokeless tobacco, and the difference is quite high. So that needs to be looked into, because we know that when the cigarettes are out of bound, then switching over happens and people resort to other products which are available. And especially true for the countries, where multiple tobacco products are present. So that becomes an issue. Then also now looking at the supply side issues, because now going beyond empower, and if we need to effectively control tobacco epidemic, this cannot be done without looking at the supply side issues. So member states are looking beyond empower also. We were given examples even, where bans have, comprehensive bans have happened, and that has beyond FCTC. So those examples are also there from the region. So restricting access of tobacco products to minors, because that is kind of, I think, very much relevant to smokeless tobacco products, because they are cheaper, and because of this acceptance largely in the society, minors, they have the access to these products. They are, they are not smoked, they are chewed, and especially when they are used in combination with areca nut, and they start early as compared to smoking products. So this is very important to restrict access to minors, and also addressing the illicit trade, because that's happening. The major hub of manufacturing is, of course, India and other countries which are around us, our neighbors who share borders with us. So these products just sneak through the borders to these countries. And then providing viable alternative livelihood options for tobacco growers and workers, especially for tobacco growing countries. We have 3 countries. India is one of the major producers, then Bangladesh and Indonesia. So when we look at the alternative livelihoods, that is for all kinds of tobacco, which is used for making cigarettes, bidis, smokeless tobacco. This is important for the region, given the huge implications of supply side issues, because if we control from the regional point of view, as well as from the global point of view, we need to have a balance of both demand and supply side issues. Now, creating an enabling environment across the region to support implementation of policies which are aimed at curbing the smokeless tobacco use. So we supported National Institute of Mental Health and Neurosciences, NIMHANS, Bengaluru, to establish an additional lab. And thanks to the Ministry of Health, they also supported this lab, and they are focusing on testing smokeless tobacco products and flavors. Other 3 labs are also doing that now. So this lab is now functional, and they are also member of the WHO Top Lab Net, along with the other 3 labs. And they are available for testing for other countries also. That's not only for India. And we recently got a request from Myanmar, so I think we'll be testing their products. And during COVID-19, there were spitting bans, India subnational level. So we also brought a flyer that time, COVID-19 and Tobacco Association, and that also covered smokeless tobacco. And we are also supporting research on smokeless tobacco. So there were some good projects which were undertaken. And we took out this tool, GenNext Exit NCDs. It's a very comprehensive tool to be implemented at school level. And it is targeted at children, school children aged 5 to 15 years. And that's prevention of NCD risk factors, and which includes tobacco. So that's an important intervention, and people who are wanting to use this, they can do that. This is available on my website. And when we have challenges, we also have opportunities. So increasing the focus on best buys, specifically raising taxes, enforcing bans on taps. And we know the surrogate ads, and now all these scenes which are there, on OTT platforms, smoking, smokeless tobacco. So they need to be taken care of, and we need to expand the support for interventions for quitting smokeless tobacco use. Already there and being promoted, but there is a lot more to do. Then we are aware of the tobacco industry interference. Speakers spoke about that, and that needs to be effectively tackled across the region. And this is also a very powerful lobby, the manufacturers of smokeless tobacco products. And as I already said, supply side issues, they need more focus and commitment. We only have India and Sri Lanka as parties to the protocol, Article 15, and we have millions of tobacco farmers and workers, which form the main group, when it comes to rallying against the implementation of tobacco control laws and policies. So that needs to be tackled. They have to be rehabilitated into other alternative livelihoods. And then easy access to youth to smokeless tobacco, that remains a cause of concern. And I am having an expert group consultation 27 to 28th of October in Bhutan on this. So basically focusing on youth. So we'll come out with some good, recommendations from that group. So I'll be sharing that in due course of time. So I think this is all I had to share, and I think I kept my timelines. Thank you so much for your kind attention.
Thank you. Thank you so much, Dr. Jagdish. So now we're going to shift gears a little bit and hear from two speakers from the field, from countries. We've got speakers from India and from Bangladesh. I will invite firstly Dr. Lema Pokpam Swasticharan, Additional Deputy Director General from the National Tobacco Control Cell of the Ministry of Health and Family Welfare in India. Dr. Swasti, could you tell us a little bit about your thoughts and your experiences from India on this topic, please? Over to you, Dr. Swasti.
Yeah, thank you, Kevin. It's a great opportunity for me to share the India experience. India, unfortunately, is one of those countries which has the highest burden of smokeless tobacco in the whole of Southeast Asia region, not just the Southeast Asia region, of the whole world. We have got about 200 million users of smokeless tobacco. That means that we have almost, 80% of what the world is having for smokeless tobacco. And what is more disturbing is the Global Youth Tobacco Survey. The fourth report also says 4.1% of the school-going children, these are children between the age group of 11 to 15 years, use smokeless tobacco. This is very disturbing. And of all the smokeless tobacco, the myriad of smokeless tobacco available in India, Kani and Gutkha are the most important ones that we have and which is bothering us. Gutkha is, to tell you, is a mixture of tobacco, the lime and areca nut mixed together. When the tobacco which is harsh in any form is mixed with a sweetener and also areca nut, which is culturally very acceptable. And then if you put lime to increase the pH so that the absorption level of the nicotine is faster and higher, the mixture is very, very dangerous. And so India has been working hard towards this. The effort is also augmented by the fact that there is the very high incidence of oral cancer in this country. So these efforts have, these facts and figures, as well as the concern, has led the government to initiate the National Tobacco Control Program with objectives of raising the awareness so that people do not initiate tobacco use, or those people who have unfortunately initiated tobacco use are encouraged to quit through the various mechanisms available in the country, which other speakers have also explained. We are also hosting the Global Knowledge Hub on smokeless tobacco, thereby, stating the fact and also sharing our experience to the rest of the world so that they do not face the burden that we face today. And to go to a case study, I would like to share the story of the Gutkha ban that we did in India. Unfortunately, the National Tobacco Control Program, the laws associated with it, which is known as the Cigarette and Other Tobacco Products Act, does not have a capacity to ban a product, completely. So we adopted what is known as the Food Safety and Standards Regulations of 2011, where we said that the product should not contain any substance which may be injurious to health. Tobacco and nicotine shall not be used as an ingredient in any food product. So while to cut the story short, we had long legal battle where the Supreme Court, decided that anything which is being by mouth and causing, giving you some nourishment should be considered as food. And once the gutkha is classified or named as a food, then this particular act comes into play, and because of that, we could ban the gutkha act. It was not easy. We had done it in a few states, and the letters were sent out to the various states to consider passing necessary orders for prohibiting the sale of gutkha and pan masala, again, which is not supposed to contain nicotine, but those which were found to be containing nicotine were also banned under the Food Safety and Standards Regulation 2.3. There had been a lot of legal challenges as expected. The tobacco industry, as many of the speakers have already highlighted, do not stay quiet. They attack you in all fronts, and the ministry has been doing that. And we have also had consistently dealing with parliamentary committees, committees on petitions, bench under the Lok Sabha of the parliament. And we have been working on these fronts. And as my other colleagues have also shared, the public awareness campaigns that we use for tobacco was also focused on hard-hitting messages and testimonial campaigns launched, and we were using SLT. If you remember, if you see what some of the pictures which have been shared by the previous speakers, we had Mukesh on harmful effect of smokeless tobacco, and another lady called Sunita. We had also had the surgeon and tears you apart, and I don't believe kind of messages which were also focused not on smoking forms, but rather more on the smokeless tobacco. Then the pictorial health warning, which is about 85% on both sides, front and are also, we also use pictures which would be related to the smokeless tobacco. And as Dr. Jagdish had also mentioned, we already have 3 national tobacco testing laboratories, and our focus, apart from the smoking forms, we are focusing on the smokeless tobacco, the flavors, and why we need to develop evidence-driven tobacco control, particularly for smokeless tobacco. The journey has not been very easy. We continue to fight. Sometimes win, sometimes we lose, and when we lose, we don't lose heart, and we go up to the higher court to defend the case for smokeless tobacco ban in the country, because this we know is going to result into saving various lives, reducing the morbidity, and also the unfortunate consequences of death and diseases caused by tobacco in the families of the persons using tobacco throughout the country, particularly the young people. This is what I wanted to share. Thank you for giving us this opportunity.
Thank you, Dr. Swasti, for your really good words of wisdom. Now I'm going to just jump over to Professor Rumana Haq from the ARK Foundation in Bangladesh. She's the Executive Director. Professor Haq, over to you to tell us about the Bangladesh experience and your insights on this topic, please.
Thank you. Thank you for inviting me to this very important and interesting webinar. Just giving a background that smokeless tobacco use is also very high in Bangladesh, and the latest round of Global Adult Tobacco Survey 2017 report shows that 21% adult use smokeless tobacco in Bangladesh, which is around like 22 million people. And if we look into the adolescents figure, and among adolescents who are aged 13 to 15 years, 4.5% use smokeless tobacco, according to the Global Youth Tobacco Survey 2013. Smokeless tobacco use is higher than smoking tobacco use among adults and adolescents in Bangladesh, and consumption is higher among women. As other speakers also mentioned, that smokeless tobacco products are very popular in Bangladesh, very affordable, cheap, and these are easily available, and their use is socially acceptable, culturally rooted, like other Southeast Asian countries. We have lots of achievements, but one of the issue I would like to highlight that the movement against smokeless tobacco is relatively new in Bangladesh, because the Tobacco Control Act 2005, that did not include smokeless tobacco as tobacco products. So it is only recently the Tobacco Control Act 2013, the amendment that defined smokeless tobacco as tobacco. So until 2013, when the rule was passed again in 2015, the movement against smokeless tobacco controls was really poor in Bangladesh. Since 2015, we have seen lots of initiatives by government, and the National Tobacco Control Cell in Bangladesh is really active, and they are coordinating the tobacco control initiatives with other civil society organizations, NGO partners. If we look into the tobacco taxation in Bangladesh for smokeless tobacco, good thing is that before the law amendment in 2015, the taxation on Zorda and Gul was there from 2003. But unfortunate thing is that the base price was so low, even with the low taxes, it hardly had any impact on smokeless tobacco use among the consumers. Another commendable initiative by the government is that in 2014, government introduced 1% health development surcharge that included smokeless tobacco also. But the challenge, as we all know, and all other speakers also mentioned, that these smokeless tobacco products are produced in such an informal setting and with the tracking and taste tracing being so weak, given the the traditional method of tracking and tracing by National Board of Revenue, all manual, no digital system. So many of them remains outside the purview of taxation because of their informal setting, and they are not in the radar of National Board of Revenue. So it is only that 21 smokeless tobacco manufacturers are paying smokeless tobacco taxes in Bangladesh. But a recent study by Dhaka International University, supported by the union, they found that more than 300 smokeless tobacco producers are active all over the country, and they shared this information to National Board of Revenue. Thankfully, National Board of Revenue is trying to identify those manufacturers and trying to bring them under the tax net. If we look into the advertisement and ban on advertisement in Bangladesh, there are policy in place, and this is where we really can say that government is really doing well, that we don't see any direct advertisement of smokeless tobacco, even not the cigarettes or other products. But the challenge, of course, we all know that there are indirect advertisement, and very disappointing incidents I would like to highlight that there is one smokeless tobacco manufacturer who pays the highest tax in the country, and every year he gets the recognition as the highest taxpayer, and he uses his designation as the manufacturer of smokeless tobacco. So we really feel that government should not recognize the smokeless tobacco manufacturers as highest taxpayers. If we look into the sale of smokeless tobacco to and by minors, there are policy in place, but there is no implementation, as all the speakers mentioned. The same in Bangladesh, that very weak implementation. So minors can buy, they can sell smokeless tobacco, they can consume. As I was saying, it's culturally rooted. So really this needs to be taken care of. If we look into the compliance to the pictorial health warning, we have ARC Foundation, we were part of an international research consortium, which is known as ASTRA, Addressing Smokeless Tobacco in Southeast Asia, led by Professor Kamran Siddiqui. So when we looked into the, collected packs and analyzed those, we found that 84% of smokeless tobacco packs in Bangladesh have no pictorial health warning, or the size were too small to read those. And we also found that around 30% smokeless tobacco packs in Bangladesh, they do not comply with the text health warnings that as per the requirement. So definitely there are policies, but weak implementation. In Bangladesh, there is no law to prohibit the sale of quantity. So I think this is a really important issue, that unless we standardize and keep selling smokeless tobacco in small sachets, it doesn't help the taxation, because tax cannot be applied, and it makes the tax collection also very complex, and it remains affordable if we allow these loose selling or selling in very small unit. And there is no ban on use of smokeless tobacco in public places. So we really need some law which can prohibit the loose selling or selling in small packs or even use those in public places. Licensing, as other speakers mentioned, that there is licensing in Bangladesh for manufacturing of smokeless tobacco, but policy in place, very weak implementation, as I mentioned earlier. Ban on spitting and littering in public places. This is, again, we have policy in place, very weak implementation, and we don't actually know that who can bring them under. If I see somebody spitting, who will take the responsibility of to go to them and say that it is illegal and do something? So the line of responsibility is not very clear, and people are not aware, even the controlling authority, that they have the right to stop somebody for spitting. So again, weak implementation. There are cessation services, we can say, but this is again very limited, and there is no smokeless tobacco cessation services within the existing health system. Again, giving the reference of our study from Astra, we found that it is feasible to deliver behavioral behavioral support, and also maybe we also found that nicotine therapy, replacement therapy, that can be included in the existing health system and can deliver through the frontline health workers. So need further studies, and government needs more initiative to enhance the smokeless tobacco cessation in the country. We talked about the tax reform. We talked about to transform the current existing tax structure from ad valorem to specific taxation, but that needs to develop the capacity of National Board of Revenue, and needs examples of other countries, that how they really transform from ad valorem taxation to specific taxation. Though we are advocating, but it needs lots of analysis and research and capacity development for this to initiate this reform. Again, the licensing, we need the digital system for tracking and tracing. One thing I would like to mention, that the marketing channel of smokeless tobacco producers is really strong. So they are using like social marketing, and as you will get the Orsaline in any corner of the country, it's same, the smokeless tobacco you get anywhere. So I think for tracking and tracing, we need to look into the wholesaler, because these marketing channel, they're strong channel. Even if we cannot find out the informal setting of producers, but the wholesalers are there. So if we can look into the supply chain and try to find out the right actor, like the wholesaler, we can definitely track and trace them. So government needs to look into that. And also there are opportunities to integrate tobacco cessation within the health system. We have very structured TB control program, maternal health care, child health care. So definitely these are the opportunities where we can integrate the cessation system within the existing health system. And we need lots of research, as the previous panelists also say. I fully agree that we need evidence-driven policy making. So we need research in this area. The last comment from my side is that Bangladesh is an example where the Prime Minister of Bangladesh, Sheikh Hasina, she committed to make the country smoke-free and tobacco-free by 2040. So we are now 2022. So this is an opportunity for the government to fulfill the dream of the highest authority of the country, Prime Minister, and take the leverage and opportunity to make the country tobacco-free by 2040. I hope that with the joint force, we can reach there, but needs the policy implementation, more focus on that. We have lots of policies, but implementation, that's where we need to focus more. Thank you again for giving me the opportunity. Thanks.
Thank you. Thank you so much, Professor Haq. It was wonderful. Now we're going to move to Dr. Shalini Singh again, who will share with us, hopefully briefly, Dr. Singh, since you're running a little bit over time, on the support that the Knowledge Hub can provide to parties. So without further ado, Dr. Singh, over to you.
Thank you, Kelvin. I'll just briefly present some of the activities of the Hub. Of course, everybody knows that the mandate of the Hub is to generate knowledge, support the FCTC Secretariat to build the capacity of the tobacco control researchers as well as enforcers, and to disseminate information. And we are doing these various activities on surveillance, monitoring, helping policy reform, describing the health effects, doing some research on economics and marketing, and training our providers. And so these are some of the examples where we had visited Myanmar when they were developing their, amending their tobacco control laws. And with the help of the WHO FCTC and the Knowledge Hub on smokeless tobacco, we were able to institute some of the recent learnings which we had from our country. And in September 2020, they adopted the tobacco industry interference prevention measures in their policy. They adopted plain packaging, 75% of pictorial health warnings, including text messages, and prohibited the flavoring agents in the tobacco. We also held an international meeting on TAPS in November 2019, where representatives from Bangladesh, Bhutan, Myanmar, Nepal, Sri Lanka were invited. And we had discussed how to take these policies forward, and various kinds of discussions and were presented to the Ministry of Health and Family Welfare, and many of you were part of this event. Then we also have a national consultation in Patna, where the health minister himself had come, and he had mentioned how he himself was a user of SLT products at one time and how he quit. And then we released different fact sheets. We enabled the state officers to institute bans or different aspects of especially smokeless tobacco in their states. And this was a very successful event. We have certain training programs, and we invite the participants from across the world to take part in various courses, as well as whenever there are updates on the GYTS or GATS or for the dental health professionals. So these are the kind of activities that we have been doing. On all World No Tobacco Day, we have excellent seminars, webinars, and make the providers as well as the general public aware of the tricks and tactics of the tobacco industry. Then this is again when we the government introduced the code of conduct. We imparted this information to the healthcare providers and all government officials as to how to deal with the tobacco industry. Then this is another program that we're going to start as an online monthly lecture series on tobacco control. Then we have several public outreach programs like establishment of tobacco cessation clinic, and we are keeping record of all our patients, how well they are faring, and this includes smokeless tobacco as well as smoking products. Then we have a social outreach to Twitter as well as through our website on various days, like the various cancer days, and to create awareness amongst the public. A lot of people visit our website. Then we publish in peer-reviewed journals, and these are some of the examples of how we what important topics that we publish on. That's all, I think. So this is the way that we move forward in our WHO FCTC Knowledge Hub. So I just, made use of this small time and shortened my presentation. So thank you very much.
Thank you, Dr. Shalini. Very good. So lastly, I would like to invite the last panelist, Mr. Pranay Lal. He's the Senior Technical Advisor from the Union Southeast Asia Office in New Delhi, India. Mr. Lal, are you there? Yes. Okay, great. You're online now. Good. So, Mr. Lal, just tell us, as we are wrapping up with this webinar, the future, what's next in global SLT?
Hi, can you hear me? I'm sorry, I've got a...
Yes, yeah, we can hear you now. Yes, over to you.
Okay, great. Thank you so much. And I'm sorry, my internet is a little variable today. And just take a moment. I'm conscious of the fact that we're running slightly over time. So before we deliberate on what is next in the global smokeless tobacco control, I think we need to understand where the smokeless tobacco sector is moving in terms of the larger global tobacco industry. So as a case in point, let's see that during the COVID period, the tobacco products market became worth $908 billion. And if you were to add the tobacco leaf industry, the critek and the BD industry in it, and the illicit market, this is well over $1.2 trillion. And it's growing at about 2.2%. Now, if you were to look at the smokeless tobacco industry, it was at around $7 billion in 2017, but it is today worth nearly $20 to $22 billion in today's terms. And it's expected to exceed $30 billion by 2030. Along with the vaping industry, the smokeless tobacco industry is growing as fast or perhaps faster because there's a huge gray market that the smokeless tobacco industry commands. And it's growing at about 4.7%, which is nearly double of what the industry average is, which is 2.2%. So we're looking at the global smokeless tobacco industry growing faster in countries that are poorer. And but that's not the only reason why we should be concerned, because we're seeing this also take prominence in countries that have traditionally been using chewing tobacco like snus in the Nordic countries. Now, we're looking at smokeless tobacco countries. We've largely spoken about gutka and pan masala and khaini and the others, but there's also dry snuff and moist snuff, there's snus and dip, new dissolvable tobacco products, for example, and of course, the ever popular smokeless tobacco products that are used in South Asia, which are finding new markets abroad. Increasingly, dry snuff and moist snuff are finding markets in South Asia as well. So there is a bi-directional movement of these products across borders. Now, if you were to look at the sector as a whole, it's the big tobacco, or the big four cigarette makers, which also have a very clear interest in the smokeless tobacco market. Philip Morris USA, for example, which produces Marlboro, also makes a snus product called Marlboro Snus. And it clearly advertises this as for when you can't smoke. So therefore, we see the smokeless tobacco clearly encouraging dual use, and clearly they're not in the business of harm reduction or cessation. We also know that the Philip Morris International and its front group, Foundation for Smoke-Free World, which has been talking about harm reduction, has been using overtly and covertly the promotion of snus and other smokeless tobacco products as a means of permanent switch from smoking. Rather, snus and other smokeless tobacco products remain integral to their addiction portfolio. So I think let us not be fooled by the tobacco industry here. We clearly know their design. We understand that they are in the business of selling an addictive product, whether it's smoked or whether it's consumed orally. Coming back to smokeless tobacco in South Asia, I think in India and Bangladesh and even parts of Nepal and Myanmar, smokeless tobacco use is growing in double digits. We know for a fact that governments do not register new companies or new brands that are being promoted locally and regionally. And therefore, it's very difficult for governments to think about effective taxation. And taxation, therefore, remains a very, very important factor for reducing tobacco use, especially among youth and vulnerable groups. But therefore, not knowing how many companies exist, how many brands exist, and the volumes they produce, there is clearly no estimate of how big the smokeless tobacco market is, and therefore the taxation, no matter how much we collect, is still a very small tip of the larger pie. And the sense that we get from the larger landscape that is evolving is that there are small smokeless tobacco manufacturers that are growing much faster and becoming regional and national brands. But of course, there is also this prevalence of tobacco use, which is being pushed by the larger tobacco companies like the Philip Morris, BAT, Altria, Swedish Match, Japan Tobacco, and Imperial, of course. I mean, these are the large players that you get to see. And of course, there are small regional players in the Nordic and the South Asian countries that are also jumping into the fray of trying to reach into international markets. One evidence of this is very clearly seen in the patent war that is taking place. If you were to go to any of the databases to see how the patents are playing out and the new varieties of products that these large companies are registering. And we see that even vape companies are now getting into the business of making smokeless tobacco products. What is a little disheartening is the US FDA permitting some snus brands to advertise within states in America. And what they're mandating is that instead of cigarette, snus puts you at a lower risk of mouth cancer, heart disease, lung cancer, stroke, emphysema, and chronic bronchitis. Now, this is the text that comes on products that you see that are being advertised in many states in America. Now, I think this is part of the larger modified risk tobacco products pathways package that the FDA has put together. But what this is giving wind to is that in South Asia and other countries where smokeless tobacco products are a major problem, is being leveraged by the tobacco industry locally to say that globally there is lack of regulation or decreasing regulation for smokeless tobacco products. And therefore, this is a leverage that such tobacco companies will be using in domestic conditions where already there is a ban. For example, we are seeing a reversal of the gutka ban that happened in 2013 in India. Several cigarette companies, for example, ITC, India's dominant cigarette producer, though it's not in the vape business or in the smokeless tobacco industry, but it has jumped into the fray to make raw nicotine, which it wants to provide to both the vaping industry as well as the smokeless tobacco industry. So everyone stands to benefit with the smokeless tobacco industry's growth and the vape industry's growth. So it's complementing the arguments that the larger tobacco industry was pushing, whether it's for advancing their cigarette sales or looking at the flip side of it, of using SLT or vape products as a harm reduction strategy. So given this larger premise, this is where we need to now start to look at how we want to redesign the narrative for smokeless tobacco control in India and South Asia and perhaps globally, because this is where I think the landscape is emerging that smokeless tobacco, which was restricted largely 85 to 90% of it, largely in 3 or 4 countries of South Asia, is no longer a concern just for these 4 countries. It's now much, much larger. And therefore, there has to be a concerted effort internationally to look at how we want to address this pandemic that is growing slowly, but surely. Thank you so much for this opportunity to present my case in point, and I'm happy to get any questions that you may have.
Great. Thank you, Mr. Lal, so much. And thank you to all the panelists again for your stellar interventions. I'm going to hand it back now to Tibor to the wrap up and finish off the webinar. Thank you. Thank you all again. Tibor.
Thank you very much. And I think that those who stayed with us, even if we went over time, this has paid off excellently, because we have heard so many other examples of implementation. We have heard your country positions, your country efforts, and also Dr. Lal presented excellently his understanding of the way forward, and also we have now a better understanding of the players in the smokeless tobacco industry. So I think this was an excellent discussion. And I thank all the panelists who have participated and contributed to this discussion. I think we need to wrap up because, by the way, the questions have been answered, I think, in the meantime. And I thank you, panelists and speakers who responded to those questions. And in fact, there was no question left unanswered, so we can skip the questions and answers part of it. And I would like to ask you, Dr. Singh, to give us 1, 2, 3 messages, take away messages from this webinar of course, just in key points, because we don't have much time. So, Dr. Singh, what are your takeaway messages?
Thank you, Tibor. I think each speaker has brought out certain important points, and I'm sure we'll give a summary of these recommendations as a document. But I think what I have taken from this webinar is that we must definitely focus on the youth, the newer products. Erica nuts is also an important product. Somehow we have not been able to link it with the control of tobacco, but it is definitely very important if we were to do a good job in controlling especially smokeless tobacco products. Market research is very important to understand their strategy, and cessation help for smokeless tobacco as well as Erica nut. And from the point of policy, preventing illicit trade and taxation measures are equally important. So these are some of those points which I think we must lay stress on. Over to you.
Thank you. Thank you very much, Dr. Singh, for this very good summary. I just congratulate to all presenters and all speakers who have contributed to this webinar. I think it is important that we have now this document which we can use, but all that rich information which was shared today just complements that is now on paper and that has been launched, and it provides us with the opportunity for further developing the documenting and dissemination of examples of best practices. And I think that as you presented the roles and the functions of the Knowledge Hub, in the many ways you could assist other countries in implementing stronger smoke-free, smokeless tobacco regulations. It is important that we continue with the dissemination of this information. So I think we could work together in putting together a specific page for this webinar, including the presentations that were presented, and we will be contacting the speakers whether they will allow us for us to make those presentations public on our website, and also a brief summary. I think we should prepare a brief narrative on this meeting, because there were so many excellent presentations, so many excellent insights into what has been done, what are the challenges, and what could be the next steps in implementation of smokeless tobacco policies nationally, regionally, and also globally. That we need to make that effort to make them available and keep them available for the wider audience. And finally, let me just thank all speakers and panelists, participants, colleagues who helped organize this webinar for making this meeting possible. I thank you in the Knowledge Hub who contributed to the organization of the session, to identifying speakers, to identifying panelists for the panel discussion. That was very useful. And your contribution, Dr. Shalini, was very important to the success of this webinar. I'm already reading some very good feedback in the questions and answers in the chat. So let's continue this work together. And I just call on the participants to take that report that was published today, take the information that complemented that report that was published today, and use it in your everyday work. And don't forget also that another smokeless tobacco talk will take place later today, and join also the webinar of the Johns Hopkins University, as we need to use every opportunity to learn from each other and make the information and the knowledge we have public. I thank you all for your participation, And thank you for this great webinar. Thank you, and all the best to all of you. Goodbye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you, everyone. Bye-bye.
Thank you.